Good afternoon, ladies and gentlemen, and thank you for coming to People with Disabilities Foundation's 12th public seminar. My name is April Banerjee, and I'm the Program Manager for Public Awareness and Education at People with Disabilities Foundation. I am very pleased to serve as the MC for today's seminar, Overcoming Barriers to Physical Health Care Access. People with mental disabilities have shorter lifespans. People with Disabilities Foundation is a Section 501c3 public charity based in San Francisco. PWDF provides legal advocacy services for people with psychiatric and/or developmental disabilities in 8 Bay Area counties and public awareness events such as this one. In addition to seminars, we produce training videos for human resource directors, vocation rehabilitation counselors, and CDs on subjects such as employment and Social Security work incentive programs. Our advocacy program provides hands-on legal representation in Social Security cases and education, employment, healthcare, and housing as these areas relate to individuals' disabilities. In addition to this legal representation, once a month we hold a Social Security disability insurance and supplemental security income post-entitlement and eligibility legal clinics, which address issues that come up after someone is already on benefits, such as overpayments, cessation, and work incentives. The mission of People with Disabilities Foundation is to provide education and advocacy for people with psychiatric and/or developmental disabilities, with or without physical disabilities, so that they can achieve equal opportunities in all aspects of life. I would like to take this opportunity to extend our gratitude to the speakers for taking their time out of their busy schedules and prepare for and be at this seminar. So thank you very much. Empirical data show that as a group, people with severe mental illness have significantly shorter lifespans than the general population. This shorter lifespan is primarily due to physical illness. Many factors have been identified as contributors to the increased rates of physical illness that lead to shorter lifespans. This seminar focuses on identifying barriers that people with mental disorders face when accessing physical health care services. More importantly, the speakers will suggest methods, health care service delivery models, and legal protections to help overcome those barriers. Please do ask questions and contribute to the dialogue following each speaker and during the roundtable discussion. Thank you for coming and for participating in this important discussion. I will now hand the microphone over to our moderator, Stephen Bruce.
Thank you, April. Today we're going to discuss a lot of evidence that relates severe mental and/or developmental illnesses to physical health care. Unfortunately, in most instances, the physical health care is not equal to those received by the general population. Some of the barriers, obstacles, or factors that we will be discussing involve lifestyle, mental health medication side effects, and some of the systemic factors involve separation of physical and mental health care and stigma. Stigma is defined as fear of mental and/or developmental illness. It is pervasive through society, including the health care profession, the legal care profession, other professions, and the general population. Other systemic factors include lack of funding for mental health care and cultural and language barriers, such as Chinese, or an individual who speaks Cantonese, who may have trouble receiving mental health care by a psychiatrist who also speaks, for example, Cantonese. Provider issues, as I said, include stigma, writing off people's complaints as psychosomatic, not having the same resources, and insurance companies not providing the same coverage. Until recently, it has been legal for insurance carriers to discriminate against coverage for mental disorders. As recently as the year 2000 in the Ninth Circuit, which covers this in other Western states, the 20th Century Fox case upheld the right of insurance carriers in healthcare to not provide equal healthcare services to those with mental health care needs. In 2008, Congress passed and the President signed the Parity in Mental Health Care Act, which says that healthcare providers and insurance carriers must provide equal health care. However, as is not unusual, the federal agency responsible for promulgating regulations has not finished implementing their final regulations. That agency is the United States Department of Health and Human Services. There are also patient issue factors in barrier existence, including lifestyle, substance abuse, exercise or lack thereof, diet, obesity, smoking, fear, including fears of going to the doctors, self-neglect, lack of motivation, and various difficulties in communicating either physical and or mental symptomatology. Generally, there is a lack of family or support and support of friends for those with severe mental and or developmental disabilities. Effective communication or not having effective communication as to both providers and consumers can also lead to a lot of difficulty in seeking gainful employment. Non-compliance with medical care, such as even not taking psychotropic medication, is another factor, and that's why we often see our clients or patients who get injections of Prolixin, for example, every few weeks. It's not because they prefer injections, it's because they don't take the pills in large numbers. We're going to, once having identified these and many other factors, go over how to remove barriers. Now, removing stigma, which is fear-based, is easy to say, but difficult to do. But different ways of doing it will be discussed. Co-locating physical medicine, including internists and psychiatrists, is another factor we look at in barrier removal. Delegating to psychiatrists those efforts that would normally be reserved for the physical health provider or internist brings up lots of issues, such as, does the psychiatrist have time? Do they have funding? Do they feel up to speed and competent to handle those kinds of physical ailments that are being addressed? The one-stop shops model, where you have mental health care and physical health care and housing all in the same location, have been shown to be highly successful. I believe they first started in Boston and San Diego many years ago and have now spread to many cities and counties in the United States. Training patients to be their own advocates and to communicate with healthcare providers, especially in diseases like diabetes and in other lifestyles, in addition to diet, such as physical exercise, are an important component of the different ways for barrier removal. It has also been shown that one way to effectuate better communication between psychiatrists and physical health providers is to require a form letter And this is a study out of Great Britain where the psychiatrist has one or two templates where they must put down the diagnosis, the kind of medication they are giving the patient, and what blood panels and other information they need. This letter is then received by the general practitioner or primary care provider, and although this model was at first unsuccessful, after audit, it has shown substantial and significant improvement and help in communication and integration of these two treatment modalities. This is a recent study from 2 years ago, and something as simple as required form letters actually can make a difference in the follow-up care of people who have been diagnosed and possibly treated with medications and/or psychotherapy. There are risk factors that are modifiable. Weight gain, the medications which cause metabolic system changes, and weight gain can be changed. The dosage can be changed. Now, why is the risk of diabetes mellitus higher? Or why do people with mental and/or developmental impairments seem to have a higher incidence of diabetes? Is something that's unknown to me, as I've always thought that diabetes was genetic. But this is another area which the speakers will address, as we often see diabetes listed in studies. We will also delve into how we can prevent mental illness such as schizophrenia and depression, and go into other areas, just to mention a few, geographic distances between patients and physical or mental health providers is one other area that can result for the significant difference in lifestyle. I'm going to now turn the microphone over to our consumer advocates and ask Mr. Rob Chittenden from Disability Rights California to take the microphone. Thank you.
Hi, everybody. I think I'm going to pursue a little different perspective. I'm going to talk a whole lot about stigma, discrimination, and how perceptions and language are quite important. Pam and I are going to share this PowerPoint, and the learning objectives are written up as you see. Explore the impact of stigma and discrimination on people with mental health disabilities. Discuss legal issues regarding access to physical health care for people with mental health disabilities, and develop strategies for reducing stigma and overcoming healthcare access barriers for people with mental health disabilities. Disability Rights California is an agency that works with people with all kinds of disabilities to help make sure that they're treated the way they should be treated. A lot of the agency, we have attorneys who answer legal questions. Also, they may do lawsuits. I work for the part of the agency that is called peer self-advocacy, and we teach people how to advocate for themselves based on the peer model. All of us who work for the peer self-advocacy program have had personal experience with the mental health treatment, and we help organize people into groups and talk about how to advocate for a whole lot of different things. Treatment, benefits, education, but we use our personal experience to help people learn from that and learn from their other people's personal experience. So that's what the peer model is about. You're welcome. Different cultural beliefs about people with mental health disabilities. On one side, certain cultures think that people with mental health disabilities are inspired, respected, just different. Other cultures may think that they're possessed, rejected, or abnormal. What is stigma? Attitudes and beliefs based on stereotypes that lead people to reject, avoid, or fear those they perceive as being different. You know, stereotypes can be harmful things. As a person who has witnessed people thinking that I have a tendency to be violent because of my life experience, that I have no ability to think and take care of myself because of my past experience. So these stereotypes are things that are not true. Part of the stereotypes can be true, but to say everybody with a mental health diagnosis has the potential of really being violent or being helpless or not being able to think, these are really not true. And society at sometimes thinks that they are. What is discrimination? Discrimination on the other side is when people act on the stigma that deprives others their rights and life opportunities. Discrimination and stigma are based on the stereotypes that drive a wedge between us and them. There are three general types of stigma: public stigma, institutional stigma, and self-stigma. I'm going to talk about only one of these. I'm going to talk about self-stigma. Because I, from personal experience and experiences of others, it's when you kind of accept the attitudes of society or the medical community that these things are true. Self-stigma is rarely discussed and can lead to hopelessness and helplessness. I think people who have had a diagnosis work hard not to buy into this self-stigma, but it's hard. When you have around you people saying you don't have these capabilities. Language is really important. People may not think about language as being hurtful and stigmatizing. All these words up here stigmatize people, put them in a box. And sometimes, for myself, when I hear the word crazy, and it may not be used in the way in which other people might use it, I still think it shouldn't be used. On a personal level, effects of stigma can lead to low self-esteem, isolation, feeling devalued, social rejection, and shame. More effects of stigma: over-interpretation of behavior, opinions of the person are ignored, they're not given responsibility, not trusted, victims of violence, and barriers to seeking treatment. Many people say that the stigma associated with their own or their family members' diagnosis was more difficult to bear than the actual illness. Studies have shown that stigma is even prevalent among the mental health provider community. Knowledge about mental health disabilities does not prelude stereotyping. One study of mental health consumers and family members cited that stigma related to mental health care accounted for nearly 1/4 of their reported stigma experiences, and it comes from the California Strategic Plan on Reducing Mental Health Stigma and Discrimination. Yet people go to mental health professionals for help when they need treatment, understanding, and support. People who encounter stigmatizing attitudes from health professionals may avoid seeking or continuing treatment. Now I'm going to talk about two different approaches to treatment. One is the medical model, and one is the recovery model. And this comes from the client movement. And a lot of it has been accepted or tried out by the mental health community or treatment people. For the medical model, mental health assessments and diagnosis too often focus on weaknesses and problems rather than addressing a person's strength, interest, and goals. The recovery model talks about hope, personal empowerment, respect, social connections, and self-responsibility. I'm not going to read all of these. I'll just kind of talk about, in the recovery model, a diagnosis is a guide rather than a name for a person. In the medical model, it's a fact. In the recovery model, people have different realities that is not one reality. And in the medical model, it's people lack insight into their own disability. In the recovery model, people choose what's best for them based on information, guidance, and support. In the medical model, they don't necessarily know what's best for them. In the recovery model, people with mental health disabilities can and do get better. Many times in the medical model, people with mental health disabilities can never truly recover. This is a quote from the Moods Disorders Society of Canada. Hope is one of the most valued ingredients in professional client relationships and the strongest predictor of positive outcomes. Once you choose hope, anything's possible. Actions that stigmatize: disrespecting, ignoring what people want, making decisions for people. How to reduce stigma and discrimination. Use plain language, language that everybody can understand. Use people-first language. Acknowledge and respect clients as people rather than disabilities. Treat the illness with the seriousness it deserves, but treat people with dignity and respect. Listen to what clients have to say. Empathize with them, but don't tell them what they feel or think. Identify, acknowledge, and explore a client's self-stigma. Health professionals are consultants who clients rely on for information, guidance, and support. I was on Medi-Cal for a while. And now I have private health insurance through my organization. Doctors say they don't treat people differently. They do. Also, sometimes physical health care professionals, when you go with a problem, think it's part of your symptom of mental illness. A woman just last week, we were talking about her going to her doctor, and she said, the doctor kept saying, this is part of your mental illness. And she kept trying to talk to the doctor, saying, no, this isn't. This is something else that's going on with me. So she had to go to another doctor and got a blood test and found out it was a thyroid problem. It was not what the doctor assumed was part of her mental health symptoms. So this is not uncommon, and it's a hard thing to have to go through. And I personally, see when, you have private insurance, you get better treatment. And I can't believe that most of the people I know are on Medi-Cal, and they aren't getting the treatment that they should be getting. Be conscious of the power of diagnosis and the labeling process. This might also contribute to a wiser use of diagnosis. Focus on a person's strengths and what he or she can do. I'm promoting what I do: teach self-advocacy, help people help themselves. And here are 3 places people can go to get information. Peer Self-Advocacy Program of Disability Rights, California, the National Empowerment Center, the National Self-Help Clearinghouse. Both of the last 2 have a lot of good information that you can get for free and download from their websites. Thank you very much.
Thank you. Yeah.
In my view, over many years of working with the population and with the Department of Public Health, people are getting mostly what you're talking about, but they're still stuck. So I think there's something more that we need to do. And I'm not sure, maybe you guys have all figured that out. I mean, I have my own ideas, but they're pretty extreme. So I hope some of you address that. So if they have this incredibly supportive professional group working with them, including psychiatrists, psychologists, doctors, where they're getting access to really good physical care, nurses in supportive hotels or in clinics who treat them with great respect and love, then I'm waiting to hear what's next. What are the other things that we need to be working on? Because I feel like I really want to become a bigger advocate. I've worked with disabled population my whole career, and then was a high school nurse, which has a lot of mental illness there too. So what next? What do we need to be working on? Because this, obviously, but okay, so we get all these pieces in place. People are still stuck, and lots of us are stuck in something. Then what? Then what do we advocate for? Because they need a lot more coaching, maybe different environments, but hopefully you guys will get to that kind of stuff.
I'll just speak a minute about that, because it's something that changed my life significantly when I discovered self-help and discovered my peers. My peers said to me, "Why not?" When psychiatrists said, "Be careful." My peers were like, we'll walk with you. And why not try? You know, we'll be here to celebrate if you succeed. We'll be here to be with you if you don't. So I think people discovering people with lifestyle similarities can provide a life-altering experience. It did for me. When I discovered my peers, I discovered that I didn't have to kind of pay attention to what doctors had been telling me all of my life was, you know, just be careful. Don't overextend yourself. And my peers were like, you don't have to buy that. So you can try. Because I think, you know, a psychiatrist told me when I was 16 years old, don't count on having a regular life. And that affected me until my 40s. Until I met my peers, you know, encourage people, hold the hope. You know, when I'm around people who are hopeless, I say to them, I'm going to hold your hope with me. So the peer experience, I think, is a wonderful thing, but I have a great bias.
And may I add something to that?
Oh, please.
Yeah, I'm Jules Plumador. I'm the community advocate for the Mental Health Association of San Francisco, and I'm also here today speaking from a peer perspective. And I absolutely hear what you're saying. I think a lot of us can be technically doing all the right things and still be feeling stuck. And that's in fact something that I've been dealing with the past few years myself. And one thing that I think is a key component, a missing piece of the puzzle that we often overlook is trauma. And many, if not most of us who identify as peers, as consumers, have underlying trauma. Either that is the underlying trauma is what caused our mental health challenges in the first place, or it comes as a result of the things that we've endured because of our mental health challenges. I think until you really start to address trauma in an individual life, you're going to keep repeating the same patterns over and over again because you don't know a way out of them. You can be doing, like you said, all the right things technically and still not be moving forward, not making progress. And that's one element of peer connection, is identifying with other people who have gone through the same things, being able to talk through that with somebody who's been there and who understands. It can also be extremely helpful to work with a therapist, a professional who specializes in working through trauma. But boy, some of that stuff really needs to be resolved before we can start to envision a future for ourselves. Because I think a lot of us, where we are for a long period in our lives, we don't see a future for ourselves because we've been told we don't have one.
Well, I guess this is a question to the panel, and I'm speaking as a family doctor who owned a minor emergency in another state and saw people from many walks of life, and also was the physician who would initiate psychiatric admissions. And after 20 years of practice, I discovered the vast amount of research onto medical disorders like periodic limb movement disorder and obstructive sleep apnea. And I realized as long as almost all my colleagues had been misdiagnosing people as having psychiatric disorders, when in fact they had physical disorders we had missed. We would recognize their daytime symptoms as a psychiatric condition rather than a physical condition that had gone neglected. I'd like the panel to discuss this because I discovered that Harvard Forensic Psychiatry was actually teaching that people with depression had caused their own sleep apnea. Something that I guarantee you no one board certified in sleep medicine would have agreed with, but was being taught forensically and forensic psychiatry It was just blew my mind. I'd like y'all to discuss the issue.
Well, let me just say initially that I think all psychiatric disabilities are really biological disabilities. I mean, the biological and genetic component to mental disabilities do make them very similar to physiological disabilities. And I think that's what a lot of people don't think about and discuss enough. We hear the term, oh, it's just all brain chemistry, but upon further reflection, I believe that in a larger sense, they really are the same. That is the physical and the mental disability, because they are based on neurology, on genetics, and they're not really that separate as the medical culture, the DSM, Social Security wants us to see. And I think a belief in the concept that mental disabilities are biological and genetic would also stop so many people from sweeping it under the rug, so to speak, because on a lowest common denominator level, I think they're basically the same. That doesn't address all your concerns, but at least as a starting point, that is my belief.
Stephen, with all due respect, I would like to say that I agree with part of what you're saying. I would also disagree to a certain extent. To the extent that there is a complex interplay between the body and the mind, absolutely, you're correct. And you can't, I think we often want to treat the mind without treating the body, or treat the body without treating the mind. And I don't think it works that way. I think we need to think holistically and take the entire organism, the entire person into account. That said, I think that it's, in some cases, there may be a biological component to some mental illnesses, some mental health challenges. But there are also life experiences that can lead to mental health challenges. And I have to be totally upfront and honest with you. I like Rob here, I come from a recovery perspective. I am pro-recovery, I'm pro-wellness. And so the language that I use, I don't like to use the terms severe mental illness or mental illness. I use mental health challenges because mental health challenges are something that are universal. It's part of the human condition. And that's how I perceive my experience. And so I think that it's also not necessarily accurate to say that approaching mental health challenges as biological and organic reduces stigma. In fact, Dr. Patrick Corrigan, with whom the Mental Health Association of San Francisco works closely, has done extensive research to show that that's not the case. You would hope that approaching mental health challenges as something brain chemistry, biological, would put it in the same category as other physical illnesses that you can test for. Apparently it doesn't. And he's done studies to show that. So I do agree absolutely that, yes, there's no way to effectively treat the mind without taking the body into account. But I stop far short of saying that mental illness, mental health challenges are always biological. To speak specifically to your question, there are things that have certainly influenced my diagnoses. I have a diagnosis of schizoaffective disorder, for example. The diagnosis of schizoaffective disorder came after I had been homeless and was malnourished, and has had a lot of nutritional deficiencies because of that. And yes?
Why wouldn't you want your diagnosis to be encephalopathy due to severe nutritional depletion rather than schizoaffective disorder?
I absolutely would. What I'm talking about is my experience was that at that time, there was no taking into account of the fact that I had been malnourished, that I had nutritional deficiencies. That was not ever taken into account.
So no one considered to re-nourish you to give you the supplements or diet that you needed
No,
before
absolutely not.
assessing a diagnosis you might carry for life.
Absolutely, that's correct.
And I hope you're angry enough about that to keep speaking out.
I am, thanks, yeah.
I can speak as a psychiatrist about this, that sleep is always something that I ask about. It was taught as one of the four sort of pillars of mental health: is sleep, appetite, energy level, and I'm blanking on the fourth one. But that's just something that should be assessed if somebody is coming in with any kind of psychiatric symptoms. And depending on how thoroughly it's assessed, has a lot to do with how much time there is in a session, or how much, what the available, whether people can get a sleep study, what the funding resource, all of these things play into that. But that sleep is one of the great glues of the mind, and so that should be routinely assessed, I think, in any kind of health forum.
There's no amount of talk therapy with that patient is going to replace the fact that your education did not include the information you needed to understand a nutritional depletion as a cause of behavioral symptoms. I'm thinking about the fact that I discovered years after I trained, and I trained at Galveston Medical School, University of Texas Medical Branch, where they favored things like shock treatments for patients. They never taught us about the long history of niacin deficiency being found to be a cause of psychiatric hospitalizations, especially in the southern United States. I found that out from a book written by a physician for the lay public. And I'm thinking, why did they leave this out of my education? Well, you can follow the money. You can simply follow the money. But I'm saying that your education is almost certainly depleted of the information you needed to make an appropriate diagnosis of an encephalopathy due to a nutritional depletion. And I would love to hear your perspective on that, but that's been my experience with looking through medical textbooks and looking at the different amounts of information you have. You can look at things like periodic limb movement disorder, which I have met people in a public setting who had behavioral forensic specialty designations at prisons, at San Quentin prison to be exact, who'd never heard of periodic limb movement disorder, which is a prominent sleep disorder that causes such severe depletion of sleep that the person is so irritable they get labeled all kinds of psychiatric. And if you put them on SSRIs, they typically will get worse, much worse, and perhaps even dangerous. And so I know as a psychiatrist, as a fellow physician, you didn't have the information accessible to you easily. Just like me, you would have probably come across it when somebody confronted you with your ignorance, or you found it in the course of reading elsewhere. I'd love to hear your perspective on that.
I respectfully disagree with you. Like I said, I feel like every assessment that I make of an adult or of a child includes a careful assessment of their sleep and their appetite and their nutrition. And if a kid's not eating breakfast, I'm a child psychiatrist, if a kid's not eating breakfast, then that's the first thing that needs to happen, is at least just get something, some yogurt or a banana or something before you go to school. Otherwise, there's no way that you're going to be able to function optimally. And so, in terms of the details of what you're speaking about, you're taught, 1,004 things in medical school. And if this is something that you learned about, we're free to learn about those things. I think it's unfortunate that, you weren't given a nutritional assessment, or that you weren't able to get that piece of things put back in place before you got a terrible diagnosis, So, or a difficult, whatever, diagnosis. That's not something that anybody wants to hear if there's a lot of nutritional things going on. If those other pieces were in place, then I guarantee your symptoms would have been quite different.
Could I address something quickly about that? My name is Veronique, and I am currently at San Francisco State doing my MS in rehabilitation counseling. And what I'm hearing is, lady, the nurse, and the doctors and you guys, we all have specialties, right? We take care of this and we take care of that, oncologist cancer, psychiatrist mental health, and so on and so forth. And in my perspective and my studies, we've been pounded on the head about diversity, about socioeconomics, about race, about ethnicity and sexual orientation and all that. And it seems that we all agree, but we agree in our own specialty, right? It's hard for me to fathom how we can change something where there's no communication among, mental health writers, doctors, nutritionists, and so on and so forth. And I think that's, what can we do, right? How can we communicate? I mean, yes, we get, our education in school, and so hence, maybe you privately read about, if a kid doesn't go to, the school with a, belly full of good nutrition, then, deficiency happens. Excuse me. But it seems to me that we all have our specialties, but yet we don't communicate with one another. And I feel like this is where, this is where the wheel is squeaking. Can you maybe address that? Because I know, doctors, I've heard that, anything that has related to LGBT, I think in entire studies, they get, half an hour on, how to treat a person who is of different sexual orientation. Same thing with disability, same thing with physical and mental disability. There's very little done to it. But yet, instead of becoming an expert in that, there are rehab counselors, there are, physical therapists, but we need to be on the same page. I don't know. It's just a food for thought.
Let me just say this about communication. Communication, and more specifically, effective communication, from a legal point of view, is the basis for eliminating the discrimination in terms of barriers, whether it's to programs, whether it's to employment, whether it's to education or other basic realms. And effective communication means, for example, a lawsuit that I headed against the Social Security Administration so that people with mental disabilities had the same program access to work reviews by the Social Security Administration's employees. Now, the employees were not trained in anything mental or even medical. They were simply asked to do an analysis with people who had autism or schizophrenia or anxiety and or depression, whether or not there was evidence of cognitive deficits. And what effective communication means is the person who's doing an analysis must have a basic understanding of the mental or developmental disability in order to apply their ordinary concepts, such as, do they have an impairment-related work expense? How would a Social Security claims representative know if someone had an impairment-related work expense if they didn't know what the disability was? Or how would they know they had an independent living skills trainer or job coach? How would someone know if someone had an unsuccessful work attempt, another Social Security Administration term, if they left their work based on schizophrenia, but the employee with schizophrenia didn't tell the employer for fear of word getting around and not getting a job? Yet they require evidence by asking the employer why the person left. Now, this is an area where effective communication between the agency, in this example, it's the Social Security Administration, and I don't mean to just pick on them, it isn't just them. And those people are very nice people, they're just not trained at the level where they do these reviews. But in order to have equal program access, meaningful equal program access, as they call it, they have to understand the nature of the mental or developmental disability and know something about the symptomatology, even to know what questions to ask. So what you're talking about comes to my mind very quickly, having spent years litigating these things. And on the bottom line, it boils down to, in most arenas where there's a barrier or divide with between some people with mental disabilities, is, why isn't there effective communication? What, all they need is training. Why don't they give it? It's because they don't do medical at Social Security. The states, the 50 states, state agencies, DDS, Disability Determination Services, they do medical. And there's where a disconnect is. And I'm sure the same kind of problem is happening in other realms. I happen to be a Social Security practitioner, so I can sit and talk about, disconnects there. But the communication thing you bring up is extremely important in this whole discussion we're having today. Please wait for the microphone, just so we and our
No, thank you for your comment. But let's talk about how we can do that.
I think it's partly, when it comes to a large federal agency, it's training. They train them on all kinds of things, but nothing as to, in disability programs, the actual disabilities. And I think it's more discourse and discussion, such as the one we're having right now. Unfortunately, this kind of seminar is not routine enough. And that has a lot to do with the stigma too often associated with mental disabilities. I mean, to come and talk about mental disabilities on a Monday afternoon is not the most inviting topic for a lot of people. I mean, who wants to sit down and talk about being crazy? And I use that in the very nicest, most compassionate meaning. And I used it, yes, on purpose, knowing that we're talking about choice of language also in this seminar and discussion. But it seems to me those are two ways. Other people may have more suggestions besides training and discourse, but at least through education and public awareness, it would seem to help bring about more effective communication.
As a psychiatrist as well, I would definitely agree with what you're saying, that communication is key. What we've all been saying, that communication is important amongst multiple specialties. And I think one area of effect of why there's not as much communication between physical therapists, psychiatrists, family, clients, is probably time. I think a lot of what we're talking about here is education and training and having more discourse on information on the recovery model, on changing the language, talking about stigma. But a lot of this is a very self-selecting population. We're coming here because we recognize that it's an issue. And I think a lot of the medical model is of where we are in training and where we are working with multiple specialties is still based on that medical model where people are caught up in and just treating symptoms, not thinking about talking to as many people, not communicating as effectively, and that causes errors, that causes people to not feel comfortable speaking up and ultimately not providing as good of healthcare. So I think having more of these conversations, talking more about how to increase communication, recognizing it as a main cause to drive better healthcare, to decrease medical errors, to increase satisfaction for providers, satisfaction for clients, is just very important. So.
May I just suggest quickly that often the amount of paper that we have to fill out before we see a physician or anyone could include that kind of thing, where you see the person very holistically.
That's true.
So are there, do they have food, housing, support? I mean, just it's a little tiny drop in the ocean, but I think that should be part of it.
You know, I can offer a little drop of support. There's a committee that I sit on that has people from GGRC, the Golden Gate Regional Center, that is a funding stream and treatment avenue for people with disabilities diagnosed before age 18. San Francisco Unified School District, Department of Public Health, and a few other agencies. And what we're really hoping for is to get a blanket consent form for release of information. Because if each one of those entities has to have their own signed piece of paper that's being faxed back and forth, if you just count, let's just say the school district, GGRC, and DPH, you're talking about a good 20 or 30, 40 minutes, potentially, by the time people are getting these things signed, discussing it, faxing it. Now, I'm all about protecting protected health information, but these things are at direct odds if you're talking about coordinating care. Our current privacy laws, which come largely out of stigma, and holding off mental health, substance abuse, and primary care, physical health, all these things we know are deeply related, but when they're separated by so many legal and bureaucratic, every piece of paper you have to get signed is another thing that's going to hold something up. And when these things pile up, you know as well as we all know, it becomes quite overwhelming. I looked at my clock a second ago, and in the hour and 15 minutes that we've been sitting here, primary care doc would probably have seen about 7 patients, possibly, and completed charting on those 7 patients. And that is just not a lot of time to be addressing the large spectrum of things that we're talking about. So I just want to second Dr. Miglani's statement that time really is not our friend here.
What I'm saying is that earlier I said that I was once told that medical doctors, got trained, but maybe half a day on issues like diversity and LGBT was one example, but it could be disability. I mean, it's very pathologizing. It's like what's wrong with a person.
Mm-hmm.
So the strengths-based approach, or the World Organization, the World Health Organization model,
Mm-hmm.
Treats that, as seeing the person as holistically as possible. But if you don't have the time, as you said, because follow the money, right? So maybe in the doctor's education, it should be absolutely included, not just half a day.
How to manage time, or how to
see a person holistically, how to really understand, maybe talk about the medical model, maybe talk about social and minority model and the WHO model and all those models that we talk about.
I think that is certainly starting to be addressed much, much more in medical schools. I mean, we had and this was back in 96 to 2000, a medical practice in the community program where you spend a week working with a primary care doctor, but a large part of the curriculum was going out and finding about organizations like people with disabilities, and going out and finding what's out there and what's available to be doing just exactly what you're saying. There's a lot of information that you have to learn in medical training and in nursing training and in all of our walks of life. There's a lot to learn. Yeah. So in terms of the proper amounts, these things are always competing against each other. And I think that it's getting better. I think that the public largely has demanded that, because they do want to be seen as a more people-centered, paradoxically at the same time that there's given less and less time to actually do that.
I'm going to ask now if Dr. David Pating could take the microphone, and he has a very interesting discussion also related to substance abuse and mental health and physical health. Thanks.
Hi, my name is Dr. I'm David Pating. I am a psychiatrist by training, and I do a lot of work at Kaiser, running our addiction programs, and throughout the state, speaking on the issues that you're speaking of now, which is, I think, many themes. One is, how do we take care of our health and our mental health and our addictions all at once? I think you're also talking, how do we change our system to make it more consumer-friendly, recovery-oriented wellness, and strength-based. And we're also talking about how do we become better individuals, and perhaps bringing in even in terms of spiritual themes into our care, realizing that we're not just all individuals with health problems, but we're individuals in communities. And so how do we make our communities more healthy? These are all the things that we're actually discussing at the state level on a commission that I'm a member of, the Mental Health Services Commission. But it's a unique discussion because it's unique to California. And I want to just, while we're looking at all the issues that people are bringing, give everyone a little bit of a pause that this is a unique historical moment that we're addressing, and even this conversation today is historical. In the 70s, we deinstitutionalized mental illnesses from the hospitals in California. Then the 80s and 90s became the era of evidence-based medicine, and now we're looking at this issue of peer movements and peer recovery and peer wellness. This is a historical process that we're in. There are still gaps in our systems as these systems begin to evolve. And I think your lived experiences are really important in identifying those gaps. But at the same time, we also need to realize that one individual may have a hard time moving our whole system. So this is where stories need to come together. We need to find kind of common synergies. And where there's will, I have really been inspired that there's a way and we can change our system. So I'm really happy to hear the comments you've made, but I'd like to put it in perspective so we can look at this not so much as a deficit that our system is broken, but where's our system working and how can we improve it? Because we actually have very good health and opportunities in California and the United States, and the question is how can we continue to have the good health that takes care of all our health, mental health, addictions, behavioral health, because there's only one health, and that's the whole body health. So it's with this I want to just share with that, and it's my little political speech, but go into what is this effort that we're talking about health burdens of mental health and addiction. First of all, I'd like to frame this in terms of what the World Health Organization is calling the comorbidities. It's the cross-intersection of mental health, of physical health, and drug and alcohol addiction. My friends in Sacramento, we refer to this as the triple whammy. We used to have co-occurring disorders and dual disorders and HIV and substance abuse and disabilities and mental illnesses, but now we're into the triple whammy. And what the World Health Organization is telling us is this is not a California problem, this is not a United States problem, this is actually a world problem that throughout the world, mental illnesses and addictions and health problems co-occur. They all come together more often than not. About 70% of those that have a chronic illness of some sort will have two rather than one, and so that's the majority of those that have co-occurring disorders. What I always say is that if you're over 50, which some of you here are and some of you aren't, you've got a disorder of some sort, and the more of those that you have, the more of those you got to watch out for. So between my back, my blood pressure, and taking care of two sandwich generations of my in-law moving in and my kids moving up, I have like quadruple whammies that I'm dealing with. And so this is probably the issue that we're all dealing with, is how do we take care of our total health? So a model of total health is emerging, and what we're realizing is that when you have stress plus a mental disorder, something happens. Something happens to our bodies, and we believe this is an aging of our bodies, a premature aging that results in us having lots of different illnesses. And one of the things that's coming out in the public health perspective is that persons with various illnesses, particularly mental health conditions, are dying early. They die 25 years earlier. 25 years. So whereas the average of us might live to 80, then those with mental illnesses and severe mental illnesses are living 25 years less, and in some states, as much as 40 years less. When we look at the reasons that they're dying, these individuals, we find it's actually a lot of preventable health conditions. Things that we tell our patients, if you took better care of yourself or went to the doctor or do what you need to do and don't eat as much salt or did a little exercise, some of these conditions might go away. A large part of it, these deaths, are cardiovascular deaths, heart and lung and blood pressure and diabetes related. But those with Again, I apologize to my peers. These were medically oriented slides, so I'm using the terminology of the studies. Those with severe mental illnesses, which is actually a Medi-Cal designation, have disorders that are much higher than those that don't, all across the board. The red bars here are higher than the blue bars. So something is going on. And so something is going on in a way that we really need to look at this, because this is not just your health. It's not just our neighbor's health. It's the health of all our communities and all the children in our communities and the generations to come. So the question that we've all been facing from a public health perspective is, how do we prevent this? How do we prevent the early deaths that are occurring from these co-occurring, the triple whammy? Here's a slide from the CDC. Our federal government is onto this problem. They realize it's an epidemic, and they have this little pyramid. At the top are early deaths. Below that is some diseases that we might have. Call it whatever you want, you know. It could be nutrition, it could be mental health, it could be an addiction, you have an illness. Illnesses reduce your health the longer you have them. That's just, the longer you have a cold, the less productive you're going to be. Then there's health behaviors, social issues, and then we're actually beginning to look at this issue of early developmental issues that arise in families related to trauma as possibly being not only the cause, but one possible cause. And our goal here is not to look at where the system is broken, but where in the many different places that we can intervene to try to resolve this untimely death. So I don't know about you, but I hope that you all live longer, and I want to live longer because I want to be able to come back to the 50th anniversary of this presentation. So we want to make sure that all of you guys and myself live longer. So let me just go to the bottom of the pyramid and kind of work up a little bit. This is the adverse childhood events work that actually came out of the organization that I'm in. That's really just sort of a coincidence, from Kaiser Permanente. This has been a foundational work on their work of trauma and health and mental health. They looked at 17,000 patients that came through primary care, and they just recorded their trauma experiences. They just noticed that people had a lot of trauma experience. And they asked, have you had one of 7 kinds of trauma? Have you had abuse, psychological, physical, or sexual abuse, violence against your mother, or living in a household with somebody using substance abuse that had mental health condition, suicidal, or ever imprisoned? And what they found out was that if you had, one of these 7 conditions here in your household, you had certain risks. If you had 4 of those risks in your household, you had a significant increase of not just mental health conditions, but physical health conditions and drug and alcohol conditions and obesity and tobacco and early pregnancy and just the things that come out of families that are under duress. So you can see the list here. And so what we realize again, and this is just more evidence from the bottom, that mental health, physical health, and substance abuse, all these conditions co-occur, including social problems like school truancy, dropout, and other things that we worry about. So there are several conclusions. Childhood adversity leads to mental disorders. So if you have childhood stresses, there's more likelihood that if there's a biological condition that causes a mental disorder, it might get triggered, or actually, we know, for example, bullying can lead to depression, which can lead to other things as an adult. Mental disorders plus stress then can lead to medical disorders. And then finally, adversity itself just leads to medical disorders. This is not just for those that lived in the family, this is everyone. In another Kaiser study, and again, it's just incidental, the data came from Kaiser. What we found out was that when we had somebody in treatment for drug dependence, the whole family actually had greater health problems, the spouse and the children. And then when you put the dad into drug treatment and took care of the stress in the household, the health of the mom and the health of the kids also improved. So we're really talking about a community problem here that's affecting not only individuals with conditions, but the whole family with conditions. If you've ever had somebody in your household have a chronic pain condition, it wears on the whole family in terms of how everyone can take care of themselves. So here you can see again This is let's say the son, the mother had been drinking. This is the father, the husband, and their health conditions more than those that don't have a mom who's drinking. This is the kids of the mom who's drinking, greater than those that don't have a mom who's drinking. So when we're looking at this problem of health, it's really not just individual health, it's multiple health, it's family health. And we're starting to evolve models how this occurs. It occurs, you take somebody who has maybe an irritable child, and you give them some family stresses, and something happens to their early parenting. Maybe they get fed too much or they don't get fed enough. And then gradually they develop behavior problems that might end up in school or adolescent problems. And from this, they might end up with having greater health conditions down the road. Because where do we learn how to eat? We learn from our parents what is good nutrition. Where do we learn how to take care of ourselves? We learn from our parents and our families how to take care of ourselves. But if our parents don't have jobs, and they're not coming home, and I had to raise myself, and I had to cook for myself, what have you got at the end? You've got a mental condition, a physical condition, a social condition, and it all co-occurs. So we've been looking at ways to how to change this through our health system, and we know that there's different prevention windows. I won't go into this in detail other than to say there's things you do for kids, and there's things you do for teenagers, and there's things you do for adults, and they're different. So when you're talking about a problem, you need to talk about who and where and how, and so in some ways it gets very individual. It gets very specific to client-centered approach, because each of us is different. Each of us grew up in a different context with a different set of needs. And so what the public health departments across the country are saying, and this is the Institute of Medicine, is that we need to realize that mental and physical health are inseparable, and we need to take a developmental perspective. How did you get here? Where are you going? What do you need to do to move on and from your condition? And this perspective needs to be one that involves your whole life. And we need to fix the problem. If you have a condition, that you don't die early, that you get the care that you need and the diagnosis you need. If you don't have a diagnosis, we need to make sure that you have the prevention you need to learn how to take care of yourself so you don't become overweight if you're pre-diabetic or you're pre-depressed. There's perhaps it's a condition, a young child that is temperamental but bullied. Perhaps it's a pre-depression state. Or we know there's now a pre-schizophrenia state that we can identify. And all the way back to identifying not only the children at risk, but the families at risk. And we need to make sure that our systems serve them well, because our systems are really fragmented. That somebody that comes in at one of these different stages bounce around. They may be a vet, for example, that after the war they didn't have a job, then they go through community mental health, and maybe they get Kaiser because they have essential health benefits now. Each of those systems has to become competent in meeting this client where they're at to prevent the early death. And then lastly, we need to look at our communities, because those communities that have the most stress are at the most risk. If you have poverty, if you're under poverty, you have the greatest amount of stress in your family versus those that don't. We know that single with kids, single mom, single dad with kids, highly stressful. We know that gay, lesbian families, another source of high social stress. And we know that certain racial, ethnic, cultural differences impact how people interpret stress. And all these things are working together to create a set of comorbidities that we call this triple whammy, this triple set of health conditions. That for each of us, our path of how we got here and why we're carrying this burden is very individualized. So we need to start with, again, a biological review, probably a psychological review. There should be a little social history we're finding more and more important. And some people are even pushing that we should make sure that people are part of a spiritual or a community-based assessment. What are the resources that you're relying on? And this can't be done in 15 minutes. It has to be done across a set of visits in a different kind of way. So that's the message that I want to share with you. Again, it's about this triple whammy. And while we're thinking about others, the more important thing is if we can share this message of health and of public health and make sure that this thing doesn't grow, then the next step is to make sure that each of us individually doesn't get whammied, because this problem begins not out there and not with the doctors and not with the peers, but with each of us becoming good advocates for good health. And that's how we're going to build a better health system, when there's enough people that will make a requirement of our health and our benefits and our public health systems, that we again address the whole person through the whole lifespan to treat all of our conditions in a way that is reasonable, in a way that will, bring us all a better health in our families and our communities. Okay, thank you very much.
Thank you, Dr. Pading. Jules, you have a question, do you?
Yeah, I wanted to first of all thank you for that presentation, because that it makes so much sense, everything that you've presented, and parts of it tie in very much to what I was saying earlier about trauma. And one thing that struck me when you were talking about some of the events that happening in a person's life that may lead to co-occurring disorders later on, things like domestic violence or sexual abuse, alcoholism in a family. One thing that we were discussing amongst ourselves was growing up LGBT in a family where you're the only one. All of those things are things that there's so much stigma around. And it goes a long way towards explaining why so many of us, I think, have so much difficulty asking for the help that we need. There's a silence that's cultivated in a situation like that I know I internalized early on, and it's something that's made it very difficult now that I'm much older, even still, to disclose, for example, my mental health history to a healthcare provider, because I've been told since I was a kid that there are things that you don't talk about. There are things that you keep to yourself because they're shameful, because there are things that you keep a secret. And so I think that a lot of what you talked about not only explains why the co-occurring disorders end up happening, but why we have so much difficulty accessing the healthcare that we need. So thank you for that.
Oh, thank you very much. And I hope that's why many of us are living in San Francisco, because this is not a town where we have to be ashamed about.
Exactly, and I think that it's wonderful to be in a community, in an environment where we don't need to hold on to that internalized stigma, that sense of shame. However, I would say that it still is difficult to overcome that,
yes.
And that's what the internalization is about. That it's wonderful to have the supportive community that we have here, but it's still a hurdle for a lot of us to overcome, to find ways to talk about it. And again, going back to the peer support and peer communities, that's one of the things that's been extremely beneficial for me, has been the ability to talk this out with other people who have gone through similar things. Yeah, thanks.
Dr. Pading, I had a question. I don't know if it was slide 18 or 19 or thereabouts. It had to do with prevention. And I did see prevention with respect to both schizophrenia and depression at some point, and I wondered, especially with schizophrenia, just without asking for a very complex answer, how do you prevent schizophrenia?
Well, I'm going to actually also invite my other psychiatric colleagues here to chime in. You know, mental disorders are complicated. For some people, there's a genetic component, there is an environmental component, a social and a psychological component. And so what we found is that most major mental health conditions have onset before probably 25. The young adult is probably when you start to see them. And so in as much as we can delay the onset of them or detect them early, we can keep disorders from actually at times becoming manifest. You can abort them, so to speak. It's like having somebody that might have a diabetes, but they might go and exercise, and so with the exercise they can avoid getting full-blown diabetes if they're pre-diabetic. So now we are understanding there's maybe a pre-schizophrenia condition that has some cognitive issues that are identifiable. So I'll turn to my colleagues on that one. And then we know there are factors that in early adolescence and early childhood that may predispose kids to depression and anxiety disorders. And we can identify these risk factors 2 to 4 years earlier than actually before people get depressed. So a lot of people are beginning thinking, here's a window of opportunity. Wouldn't it be lovely if, before you even get the stigmatizing disorder, that we can look at the conditions that might put you at risk? And so in California, we have enormous school-based prevention efforts, which I'm hoping actually my colleague, Ms. Cohn here, might speak of some of the prevention efforts that they're trying to do in the UC system with regards to early detection, perhaps by the teachers, of some of the risk factors, because a lot of it comes out in college. You've left home, you lose your family support. If you're going to fall apart, that's where you're going to fall apart. So, but let me turn to my other colleagues, because there's also a biological component to this, and see if you have any other comments about preventing mental health conditions.
Certainly identifying early concerning hallmarks of schizophrenia, and keep in mind schizophrenia is really 5 diagnoses. It's a varied, there's a paranoid schizophrenia and there's undifferentiated, and so that was back with DSM-4, DSM-5. I'm not quite even sure about how it's categorized. But there has been lots of thinking and discussion that if you can identify the prodromal syndrome, say a kid that may be in his room isolating a lot, talking to himself or something, becoming a little bit more paranoid, withdrawn, then you may be able to arrest some of those symptoms, because psychosis actually builds on itself. The more withdrawn and isolated you become, the more your touch with reality or with other people it becomes more tenuous, and it tends to just build on itself. So the idea is that if you can stop that earlier. Now, the issue that I have with some of those early identification efforts is that often medications would be a part of arresting the symptoms at an early age, and I think that you have to be very careful, because as we know, many of the medicines that are used to treat schizophrenia are very potent. They may help with a lot of the symptoms of psychosis or mood, but they also have many side effects that you want to be extremely careful about starting for a young person. And so I think it is true that once you have a clear sense that, and again, that you've looked at the nutritional aspect of things, you know that somebody's sleep is stabilized, and you sort of opt the family has education so that they're not in a highly emotionally charged environment, and things are just calmer and supportive. Then it would be time, if their functioning was significantly impaired or becoming worse, to consider medications in that case. And then you do have a better chance before a psychotic episode becomes really, really difficult to get back, to reestablish some of those connections and some of that being in touch with the reality that it actually allows them to function.
So once you've detected some symptomology, knowing that, I guess for men, the average age for onset of schizophrenia is 25 or whatever it is, then you would know that there may be an opportunity to forestall or stave off the more symptoms.
25 may be an age that most people, most males, would be diagnosed with schizophrenia, but probably by the time they were diagnosed, the problems have been going on for some time, because as we know, people only often will confront these things when they have to, when they're no longer avoidable. And so by that point, someone may in fact be pretty ill. A lot of the symptoms really you may end up seeing when they're 17, 18, 19 years old, just at that juncture of having to leave home, think about adulthood and being out, and without a path or good supports, and talk about the socioeconomic and social pressures on a 17-year-old these days are enormous, and that tends to be one of the most fragile times.
And by definition, there's a gradual onset with a psychosis. In other words, if the average age of diagnosis is 25, we would assume there's a gradual onset, and that's why we would want to start looking at symptomatology age 16, 17, or even before, knowing
Yeah.
that it takes 9, 10 years or thereabouts.
But even in the most knowledgeable families, there's such a pull to want to avoid confronting or actually believing that there's something really going off track.
Absolutely, and there's a lot of rationalization that goes on. Nobody wants to believe that someone in their no one wants to believe that their child is schizophrenic, is going to have this label for life. Families, in my experience, certainly in my own family, will do just about anything to avoid looking directly at the situation and confronting it head on. And that's completely understandable. That is a normal reaction, I think, that kind of denial. But that's something that we have to contend with, and we have to really work on education efforts, stigma reduction, and let people know that this isn't a life sentence. Because a lot of parents are coming, even now, coming from a generation where they heard that schizophrenia is for life, that's who you are. That's what your life is, and that's what a lot of us who have lived long enough to have had a diagnosis like that for quite a while have heard as well. So it's something that is very scary for families to confront. You're absolutely right. It's something that early intervention works, and it can really, really make a difference for a lot of transitional age youth. But there is that hurdle, that barrier to get over, that you actually have to identify that that's what's going on.
Thank you. Dr. Holt, do you want to continue on with your
Sure.
presentation?
My presentation will be fairly short because many people have covered the things that I was also going to talk about, so which is fine. I'm happy to get through it, and there's certainly some new things in there too, but I won't belabor things we've already talked about. So the prevalence and disparities, as we've been talking about them, I shall look down here, is that it's a number that we've just heard a couple of times, that people with severe mental illness, again using the Medicare Medi-Cal designation, including schizophrenia, bipolar disorder, schizoaffective disorder, and major depressive disorder, have an excess mortality of 2 to 3 times as high as in the general population. And I also thought it was important, as we've been talking about this, to consider developmental disabilities, which are treated with many of the same medications as the disorders that I listed earlier. People with these disorders have a 13 to 30 year shortened life expectancy, and 60% of that is due to physical illness as opposed to suicide or other reasons. Some disparities are due to modifiable risk factors and lifestyle choices, but others are due to access and utilization and care provision. And these are the things that we've been discussing a lot today. The care provision in particular, when we think about medications for many mental illnesses, actually are going to significantly impair somebody's ability to live a healthy life as far as their physical health goes. So this is just a list that I didn't look at any journal or anything like that to come up with. I just this is what I was off the top of my head in terms of what I found myself working as a psychiatrist that's done really the past, 8 years as a consultant for primary care. What I've seen are the biggest issues. It's a confluence of provider, client, and system factors. And as Dr. Miglani had said earlier, I think that time is certainly not our friend when it comes to treating people in general, but particularly people with disabilities, emotional and psychological disabilities, because there already is such pressure on your time, especially for a primary care provider, for a specialist, that if they feel like there's going to be some barriers to that communication, then there's stigma right off the get-go, and because they're already thinking, this is going to take more time than I have. I have 10, 15 minutes to see this patient, in addition to do my charting, ordering whatever labs that I have to do, and putting in whatever referrals need to be put in, whether to behavioral health or otherwise. So along with this is the information systems that we use, they don't communicate with each other well. And along with that, of course, we have privacy laws that prohibit us from sharing information without very airtight releases of information. And so, like I was saying earlier, the more of these that have to be signed and passed around and faxed between people for the protection of patient privacy, but unfortunately they do work against being able to coordinate care effectively. Along with that is funding streams. There are two very, very different systems in California. The federally qualified health centers that are primary care and other specialty services, and then there's behavioral health. And the money is coming from two very different sides. And so it's not only that we have privacy laws, but we also have very different computer systems, and there's just traditionally been very little impetus for sharing this information. There are more barriers to sharing it than there are incentives for sharing it, actually. I hope that that will change going forward with the Affordable Care Act and the need for more systems to be talking to each other. Right now we're in our infancy. It's almost like if people remember back in the early days of Apple and Microsoft, where if you wanted to get something from one to another, you just couldn't because they were competing against each other. And that's kind of where we are in terms of information systems. We'd all love it if down the line we can have an easy tablet that would work for lots of different settings and situations as long as things are taken care of. But it's quite complicated, especially with our current laws. Substance abuse is a whole other realm that has even more strict. And as we learned from Dr. Pading, substance abuse can really inform somebody's health in so many ways. And then the last thing was stigma, which we've talked about a good bit today, but it's provider to client in some cases, and then it's also client to provider because they might have had bad experiences to begin with or over their lifetime, and they want to avoid feeling re-stigmatized, or they're wary about it. That feeds also into the self-stigma that was spoken about also, where you don't want to confront the fact that you may have some difficulty or want some help. It may just be hard to make that leap or to make the changes that are recommended of you, or you just don't want to hear it again. So there's on multiple levels, people tend to avoid seeking out help until it's later than would be optimal in many cases. We work in sort of a crisis-driven model a lot of the times. And so, but I do want to be hopeful here. The current efforts within San Francisco Department of Public Health for integrating these systems so that there is easier communication are attempting to look at releases of information and ability to share information, at least between more systems. You can't obviously share, you have to protect privacy, but at least if a primary care doctor is working with a therapist or a psychiatrist and still under DPH, for those two to at least be able to talk to each other freely. So that's one thing that they're working on, but then the concept of a health home where there are nurse practitioners and more of the, I'm not sure about the number currently. I think that there's in 4 CBHS is Community Behavioral Health Services, clinics in San Francisco. And so they're going to be part of a health team. And so that's both having some physical health providers in the mental health clinics, but also having much more mental health capabilities within the primary care setting. And that's sort of what I mostly do, is do consultations with primary care doctors to help them to manage behavioral health, psychiatric issues for a patient who wants to just be seen in primary care. They don't want to go, to clinic and that kind of thing. So telepsychiatry, it's in its infancy. It's been around, but primarily in rural areas. But right now, we can offer it in a limited number of primary care clinics in the community. Eventually, I anticipate, just like in the private sector, that you'd be able to see a psychiatrist or a therapist online if that's your choice. And that way, it removes at least that barrier of having to, go somewhere, get parked, spend the 30, 45 minutes, with your therapist, get back to work. These are things that in a busy world, at least is an option. And patients that I've worked with that have done it have enjoyed it. They find it convenient. I don't think it's a substitute. I still like to see patients in person, but not. But if it's a check-in or something like that, then it actually works quite nicely. They're doing smoking cessation groups in lots of the primary care clinics currently to help address. We were talking about schizophrenia and smoking and how there's a very high concordance there. To try to address that at least some way, probably in a harm reduction manner. And then, as I said earlier, information sharing. I will touch on something that Dr. Miglani will talk about a little bit more. We just did a psychiatrist survey in CBHS, and very few of the psychiatrists currently are comfortable prescribing medications that for treating physical illness. In other words, something for cholesterol or something for blood pressure, something for diabetes. They want the primary care doctor to be in charge of those. And it's understandable, it's long held that there's scope of practice. It's one reason that primary care doctors have traditionally been very wary about prescribing psychiatric medications to their patients without substantial backup, and even in some cases they just won't do it. And it goes both ways. And so you really are making it, you're keeping the walls pretty tight. I think the scope of practice will have to be looked at if we want to see more of that. But I thought that was an interesting finding. They are comfortable. The good news is that they're comfortable like with prevention counseling and things like that, and they do try to address smoking and other health concerns, but in terms of actually providing a prescription or care, that's very unusual currently among psychiatrists, and vice versa among primary care docs. So that's really my whole presentation. Happy to take questions, or we can just keep moving, whatever.
The young lady up front.
My name is Janelle, and I'm a staff attorney for People with Disabilities Foundation. And I just wanted to touch upon something that you mentioned that we've had issues with regard to provider to client stigma. We had a client recently who we represented in a Social Security matter who had a diagnosis of psychotic disorder and NOS. And while we were representing him, he developed scoliosis. So we made arrangements for him to see an orthopedist. And on the day of his appointment, he called us in a panic because the doctor didn't see him. And apparently he was ushered into the treating room, and the doctor never came into the treating room. And so we investigated the matter a little bit, and it turned out that on top of his chart, someone had written schizophrenia in black letters. So the orthopedist looked at the chart, set it down, and left the office. So those are the kind of issues that we're dealing with, that less about stigma between psychiatrists and our clients, but other physicians and our clients.
Mm-hmm.
So just wanted to mention that.
And it's sad to hear that. I don't encounter it that much because I work with, to me, a pretty great group of primary care doctors and occasionally specialists. A great surgeon that's really open-minded and good is one of the best people in the whole world. They can do things that very few other people can do. But many surgeons, that's not their specialty. that's not where their strengths are. And so that should certainly be brought to people's attention, and that surgeon needs a little bit more training and education, and because they also are fairly responsive usually. And I'm sorry that happened, but I hope that that's not anywhere near the norm. Yeah.
I also had a quick question for Dr. Pading.
Mm-hmm.
With regard to substance abuse, if the goal is overall health, mental and physical health, what is the current research with regard to whether the abstinence model or harm reduction model is better?
Well, I mean, I don't know if people understand the question. So it's a question whether you should, if you have a drug problem, whether you should completely stop, or if you won't stop, should we tolerate you not stopping, and which is called harm reduction. And I don't know if there's a better or not better. This is really what's appropriate for the client. I have some clients that when they are with other people that have stopped using or drinking or drugging, they feel more support, because there's, just to have somebody sometimes coming in a room that looks like they're drunk or stoned, it could be a trigger for people. So I look at it more when I work with my clients is, what's best for them. And certain systems, this is more of the historical thing that I've been talking about, have evolved either more abstinence-based because of their recovery model, or if they've been associated more with community mental health, more of a harm reduction base. So it depends on who you're serving, the goals of your program, and and what the individual right in front of you needs. So I think it's sort of a false dichotomy to say one's better than the other. They both are good, and applied to the wrong person, they could be both be bad. So what does that person need? And that's the best treatment. And that's the hard part, is getting everyone to get individualized care. So how do then we assess and train everybody to receive that assessment? And that's kind of, I think, the message that we want to do, is that let physicians know about this intersection of health, so that when they're thinking about diabetes or their drugs, that they're also asking, have you ever been depressed because of your diabetes or because of your drugs? And the same thing on the other end, it sounds like we need to train psychiatrists to say, certain of my medicines might make your diabetes worse. Oh, by the way, let's check your diabetes. So it's a two-way kind of intersection here. But I want to just actually leave with one last message and hope to get this one out, which is, as you can see from Dr. Holt's example, there's a lot going on in San Francisco and in the state and in the nation regarding this integration, bringing the house of medicine together. And there's actually a lot of pressure to bring medicine and behavioral health together, because if we don't, people won't get their funding for clinics and the doctors won't get reimbursed. There's actually financial incentives now. There's also financial incentives that everybody should have health. We actually just recently passed several laws in California which will make California and the private insured plans, the essential health benefits, have the most substantive mental health and substance abuse benefits pretty much in the country. And in the public sector, namely our Medi-Cal sector, our expansion benefits are probably the best anywhere in the country as well. So California as a whole has enough money, and there's pressure pulling together the medical system. What I really think is missing in all of this is still training us as consumers, as clients, as peers, how to either access and get the health that we deserve, work together to demand or motivate clinicians to provide the health that we deserve, and then working, with clinicians in a new and different way. So we can get our doctors and nurses to do something, but again, as peers, if we're not really sure how to play a part in this new kind of, it's called collaborative decision making. It's the new model, and it's based on evidence. It's based on that if you tell somebody, look, here's your choices. You can take this pill, or you can get this shot for your diabetes, that they'll have a choice and their chances of complying will go up. But if they don't give them a choice, usually compliance, which is really half the battle. It's getting people to take the medicine, or to do the exercise, or to eat the greens that your mom says that you're supposed to eat. That's the whole thing. It's these behaviors that we all know that we should be doing, that I don't do. My kids are selling chocolate bars in school, and who's eating them all up? It's me, right? We all have these little things where we know we can improve. But how to be better at advocating for our care and be better about our self-care, that's the challenge of the next century for health. And that's where I hope that, again, our peer colleagues will show us the way, as well as our physician colleagues will provide us the opportunity, the information that's coming in an evidence-based way. All I know is Mediterranean diet, greens and nuts, greens and nuts. That's my mantra right now. And chocolate? I know.
Dark chocolate in small quantities. And I have a couple of comments just in response to that. First of all, I think you make an important point that a lot of the issues we're talking about are by no means unique to mental health consumers. I mean, we all have difficulties, as you say, complying with what we know we're supposed to do. We all have anxieties about going to see a physician from time to time. That's why we have white coat syndrome, which is what makes your blood pressure shoot up 10, 15 points when you go see a doctor versus what it is the rest of the time. I mean, these are things that a lot of people deal with, and I think that it's important to acknowledge that so that we get away from that idea of us and them. We're all in this together, and we're all dealing with situations that are very similar. And to the subject of harm reduction versus abstinence, I wanted to comment because I think a lot of people are aware of what the benefits of abstinence can be, because that's been a model that's been highly touted for many, many years. Not everybody understands what the benefits of harm reduction can be. The benefit of harm reduction is that it provides an option for people who aren't willing or able to discontinue the use of their substance of choice at this time. There are a lot of valid reasons why people use substances, for example, or why people self-harm, why people do these things. These are coping mechanisms that, for whatever reason, work for people to the degree that they've become dependent on them. I hate the term something being a crutch. I've heard that many times in my life, that alcohol is a crutch, because I think it misses the point. Who needs to use a crutch? Somebody who's having difficulty walking. And so if someone is able to practice harm reduction, if they're given the option that we can look at making your use safer, we can look at tapering off over a long period of time. Let's look at the benefits of continuing to do what you're doing the way you're doing it versus the benefits of changing. If we can look at those things and work with someone, and that's something that I do in peer counseling regularly, these are things that give people options, and they allow someone to take control of their life in a way that they may not have been able to before. And that's, as you said so eloquently, it really depends on the individual. There are some people who are going to end up being abstinent for the rest of their lives, and that's the right choice for them. There are other people for whom harm reduction is a great option, and a lot of times it can be very beneficial to learn how to do something in moderation over time, and that can be very empowering as well.
I just wanted to comment further on the problem of barriers to accessing healthcare. I know of an individual who has a diagnosis with of a psychiatric disability, and she also had a toothache. So she went to the dental clinic to seek treatment for the toothache. She filled out, it was her first time at the clinic, so she filled out the initial questionnaire, and on that questionnaire it asked what medication she was currently taking. So she listed all the medications she was taking, including her psych meds, Seroquel. She was seen that day by a dentist, but it was determined that she needed to have a tooth extracted, and so an appointment was set up with an oral surgeon. When she went back to see the oral surgeon, they refused to do the surgery and told her that she needed to bring her entire psychiatric chart back to the dental facility. Now, this person has anxiety issues, and she could have handled it a couple of ways, but on that day she decided to stand up for herself and say, no, I don't see what my mental health has to do with my toothache. And so the surgeon backed down and then said, well, we just need a release to do the surgery from your primary care physician, and they backed down on the position of needing to see the entire psychiatric chart. But that type of barrier, if she had been in a different frame of mind that day, she may not have felt strong enough to stand up for herself, and she might have just gone home. So I'd like some comments on that.
I'm wondering what the panel thinks about this kind of overt discrimination happening now, the year 2013, here in the San Francisco Bay Area. On the one hand, we're talking about San Francisco and other places are really moving forwards with integrated models and telephone appointments with psychiatrists and peer-led groups, which is as beneficial as anything else, or even more so. And yet, on the other hand, we've just heard two stories, one with the orthopedist and now a dentist here. Is this overt, what I call overt discrimination something that is just going on side by side with all these advancements and ideas of, the home health homes. Is this what is the reaction of the panel to this kind of thing? It doesn't seem, or is it so random?
Yeah, I think it's better in San Francisco than it is elsewhere. Certainly, I think San Francisco has really made a concerted effort to implement a recovery model and harm reduction in a lot of city-funded programs. That said, as much better as it is here than elsewhere, we're not totally there yet. I mean, there are still people that need to get the message and who need to be educated in terms of stigma reduction. I mentioned that I'm part of Speakers Bureau Solve, Sharing Our Lives, Voices, and Experiences. We go out into the community and we do presentations on stigma reduction to all sorts of different audiences. And included in those, we speak to medical students. We speak to physicians. We talk about this stuff, and we open the dialogue around it because there is work that needs to be done still, regardless of how great San Francisco might be in comparison to other places. There's still definitely work that needs to be done.
I just say that throughout the state, the issues of stigma and discrimination are pervasive, and they're very hard to address. You're really talking about culture change, education, and a sense of awareness and exposure. And I think that there's just many things that have kept those barriers up. I'm actually going to address something controversial because I do wonder about it and address it to maybe some of our lawyers, whether even the way that we've framed mental health confidentiality or substance abuse confidentiality itself is stigmatizing by saying that mental health is not part of regular health, that it's something that's different, that has to be protected. Aren't we saying that, well, it should be hidden and maybe even a sense of shame around it? So I'm trying to find the balance here from a perspective of, again, as you're saying, the benefits of for example, NAMI speakers or peer speakers speaking about their health as a process of one of sharing and recovery, and yet hiding that recovery because of the fear of sharing. And so I understand that we're trying to look at, it's a historical thing and we're trying to protect, but it's a fine balance here, and I'd be interested in that because I think part of that is at the root of some of the medical stigma that
I agree. We were actually talking during the break about HIPAA regulations, which is the Health Insurance Portability and Accountability Act, which especially when it comes to mental health issues, can be really counterproductive. I was talking about one specific example that we've had at MHASF in terms of using photographs at conferences and whatnot of people who identify as mental health consumers. And we are not legally permitted to use those photographs, even with the permission, the express written permission of people, because if they identify as a mental health consumer, it is not legal for us to do that, is our understanding of HIPAA regulations. And that sort of implication that we as consumers, as peers, are not able to give informed consent by virtue of our diagnoses is really troublesome and problematic. This is something that we've investigated and has been ongoing for some time. So if somebody has updated information on that, I would love to hear about it. But it's yeah.
You're saying that even with a release from the patient, it's still illegal. Well, it's a surprise to me. But let me say this about the two conflicting sides. It is true that in the employment arena, if word were to get around, wherever it is that an individual works, or whatever kind of work an individual does in any geographic area, it may lessen his or her chances of getting a job. I mean, that is a reality of the workplace, and things haven't changed that much. And I'm not talking about Mental Health Association, San Francisco. There are small businesses where there's a lot of interaction with the public and the worker, and it is an area where I can see why an individual would not want to tell someone, so an employer or prospective employer may find out that they have schizophrenia, because frankly, because of stigma in another way, that is, scare away the customers. Now, I'm not saying that's true. The customers would be scared away, but there is that fear in the workplace.
But it's up to the individual whether or not they choose to disclose that.
Absolutely.
And
Absolutely.
that's what we're saying. I mean, it's a decision that ultimately needs to rest with the individual. And
Yes.
HIPAA laws don't always permit
Yeah.
that.
Yeah, I was just thinking of a way where you'd really want to have someone who's looking for a job and had to give one up because of their schizophrenia, maybe would not want to put down reason left employment, schizophrenia. That's just something that comes up. From time to time, I've seen it with some of our clients when the Social Security Administration, you have to tell them why you left, and it needs to be disability related. But then again, are you really going to tell an actual employer? Do you want them to know that they have schizophrenia? Because how is that going to affect your chances of getting your next job?
You're not going to get it.
That's right. And it's something
I just think something, though, to interject is that certainly the stigma still exists, and it is causing problems. There's no doubt about that, and that there's a long way to go to decrease that stigma. If we draw the parallel to LGBT rights or even to civil rights, that it really was people who were experiencing the stigma and the discrimination being peer advocates and sticking together and advocating for themselves, being more visible. This is a two-way street here. People are much less likely to stigmatize, maybe after they had this experience with a woman taking Seroquel. If things went fine, then maybe they won't be so averse to treating somebody that's taking Seroquel in the future. The same thing with this. So this is not to say that there's not huge problems. And they probably are better here than in San Francisco than in most other parts of the country, you might even probably say. But if there's not more, and it goes along too with what Dr. Pading was saying, was that as long as we do have these fierce, intense privacy laws where people do feel like, oh, this is my secret, and I'm not going to tell anybody, then I don't know that we're going to make a whole lot of progress if it's not working in both directions.
So here's my hope or my aspiration. At the turn of the century, it was tuberculosis, and individuals with tuberculosis were swifted away into asylums in the mountain. In the 70s and 80s, we had the worries of HIV, and now Magic Johnson is the owner of the maybe National League pennant Dodgers and has a very successful career. My hope is with mental illnesses as well, is that we'll overcome, at least in the House of Medicine and Healthcare, a sense of equanimity that, to see these on par with mental and physical disorders. That is the law, by the way, with mental health parity, is that at least financially, there's an obligation to treat them the same. And again, I hope in terms of the level of care, that same parity will exist. So that's my hope. Don't know how many decades it'll take to get there. So you hope that you'll stay there at the end when we do. So.
Okay, let's move on to
Even there was actually a question here, real quick, okay?
I'm a primary care physician with DPH, and I do half a day a week at the Tenderloin Outpatient Clinic, which is a mental health clinic a few blocks from here. And I've
And
been
a great one, I'll add. Yeah.
for 10 years.
We love Dr. Zevin.
I also work at Tom Waddell, so Dr. Zevin. And I think I totally agree with Dr. Pading and have for decades on, the triple threat or whatever it is. I think there are also other reasons for the disparities. we have a very difficult system with the SPD Medi-Cal managed care lately. Having to go to San Francisco General, I've had 2 people refuse colonoscopies, even with escorts. So that's another difficulty. There's also the issue of many people, if they have severe mental disorders, they are poor. They're going to be on SSI. In San Francisco, oftentimes that means they're going to be in an SRO, single resident occupancy hotel, which means oftentimes they're not going to get much physical activity. They're going to be smoking. They're also going to be eating a ton of fat and sugar. So you have that deconditioning and overweight. You also, if you don't value yourself, you're not going to be motivated to make the huge changes necessary to improve your physical health. So I just wanted to add that as another barrier, and also add that I teach medical students, and I do teach them a lot about mental health and respect and stigmatization.
So I
Thank
think you're
you.
pointing to things that these sort of circles. I'm just sort of imagining where people are lying or falling out. I mean, one is, again, we want collaborative care in the office between the doctor and the patient, but then there also needs to be collaborative care between a community clinic and its community, and around the Tenderloin Health Clinic, for example, or others. There's things like full service partnerships where we're meeting people where they're at. Always it's a conversation of meeting clients where they're at, the health system and the peers and the clients. And some can make it to clinic, some can't, but I think, again, we're looking from a public health perspective. It's not a one-size-fits-all. It's not abstinence, it's not harm reduction, it's not in the clinic, it's not out of the clinic. We need to have a flexible set of options of something so that people, that whatever it takes to get people healthy, we can get there. There's the balance of the resources, but where there's a will, I've seen many things in our city. There's also a way. There's providers that want to do it. There's consumers that want to reach out, and somewhere in the middle, there has to be a rational voice to say, look, let's just go ahead and do this. It didn't work for this person that went to the dentist, but it's going to work for the next person, and that's really the hope and vision that I would hope that we would all be able to carry forward.
And there are some terrific programs right now that are addressing some of the specific concerns that you mentioned. For example, just a quick shout out to the AIMS project, the Alleviating Antipsychotic-Induced Metabolic Syndrome project, which meets at Tenderloin Outpatient Clinic and is addressing some of the nutritional aspects of what you were talking about with SRO living and that sort of thing. So great stuff.
That actually ties in really well into my talk about having primary care in psychiatry and maybe some of the smaller lifestyle measures that psychiatrists, mental health clinicians can address. And that's part of, I'm a public psychiatry fellow, so that's part of my training and education into looking into these health disparities and having more conferences and so forth like this. And the South of Market Mental Health Services actually also touches on integration and so forth, another CBHS clinic. So I did add a disclosure slide because I think industry is also a huge factor into all these access, healthcare disparities. It has another huge influence into why people make the choices that they do, their lifestyle choices. So I have no financial interests or any relationships to disclose. And some of the objectives that I hope to talk about, which have already been addressed by many of my colleagues on the panel, is areas where psychiatrists can incorporate primary care into our practice, recognizing some barriers to providing some of this basic primary care, and brainstorming solutions to increase collaboration as part of the. So starting with a slide, smoking is a main factor, and it doesn't just apply to people living with mental illness, but to everyone, including Olympic athletes. And tobacco use is the leading cause of preventable cause of death in the United States. But people who are living with mental illness are twice as likely to be smoking. And sometimes people may be thinking if they're smoking, they're at higher risk of smoking, they might not want to quit, but they do have very substantial quit rates as well, comparable to people, to just general people, because that's what we all are. And once again, just kind of highlighting how high the smoking status is amongst people with mental illness. It's almost, as I said, twice the number. So the numbers that are more statistically significant are the lifetime smokers, if you ever had a mental illness or any mental illness in the past month, 59% of are lifetime smokers compared to 39% without mental illness, or 55.3 if you've ever had mental illness, compared to that number 39%. So this was a population study in 2000, and there's more literature in the CDC and so forth also talking about smoking cessation and making it a larger public health issue for primary care, for psychiatry, behavioral health to be addressing. So one of the things that as a psychiatrist we should be doing, hopefully, or any type of clinician involved in caring for people with living with mental illness, is to always ask about the smoking history. And it seems so simple, but is often just not done. There are a number of things to be done in your 15, 30-minute check-in, and asking about smoking's history might just go to the wayside compared to cocaine, methamphetamine, all these other illnesses. But knowing that if there's one thing that you could be doing in an abstinence model, a harm reduction model is just addressing smoking cessation, it's always a key area to be discussing. So asking about it, advising for smoking cessation, bringing up some of these factors and how it can be factoring in on multiple things, not only their health, but also the economics. When you might not have the most money in your wallet, paying for cigarettes is something that people might relate to a little bit more if you're talking about how much it costs. And then knowing what resources that we have in San Francisco. As we mentioned, there's smoking cessation groups. Sometimes people don't feel comfortable or don't have the time to go to the smoking cessation groups. And across the nation, there's a bunch of telephone hotlines. So there's 1-800-NO-BUTS here, knowing when to refer for it. There's treatment that we can provide, and there's nicotine replacement therapy, Zyban, which is actually Wellbutrin, so you can be targeting both depression and also targeting smoking cessation, and Chantix as well. And then just knowing that smoking is something that is very difficult and has a lot of different factors in why people are smoking. There is a higher rate of people with mental illness smoking, and that's probably because it can decrease anxiety, it can decrease tension. There's a social aspect of smoking. If your peers are smoking, you may be smoking with them, addressing some of these environmental figures, and it can even have some biological factors, improving your attention, improving your concentration. So there's a lot of reasons why people may be smoking, and knowing and being aware of these issues so that when people decide, okay, maybe I will try smoking, that you can counsel them to be aware of some of these issues, that they may have withdrawal, that it may be difficult, and one time if you stop, it doesn't mean that that's the end. So one other huge factor is that there's nicotine withdrawal, but there's also medication adjustments. A lot of the medications that we prescribe for people with mental illness is affected by smoking. So once you stop smoking, the rates of these medications might go up. And smoking in itself may also make these medications then less effective. So there's a huge push these days for hospitals to be smoke-free. And we send someone into the hospital, they get stable on a medication, and they come out, and if they resume smoking, that medication might not be as effective. So that kind of leads into the other thing, that you have all these medications that we prescribe, and a lot of them have side effects and drug interactions and so forth. And one of the main ones is metabolic syndrome. So this is a syndrome that is commonly caused by atypical antipsychotics. And we don't just use this for people with schizophrenia or bipolar disorder. It's commonly, as I was mentioning, the industry it's used so pervasively. So the idea of Seroquel, going to the dentist, being aware of that medication, people commonly prescribe it for anxiety, all of these off-label, but they have very serious side effects. Obesity, the waist circumference, this is a a whole bunch of criteria of what it can cause. So it can cause abdominal obesity, elevated triglycerides, that's your fatty acids, elevated cholesterol, both, and decreasing the good cholesterol, which can help you in terms of prevention of heart disease and so forth.
Exhibit A right here, by the way, gained over 100 pounds on Zyprexa.
It is very disabling, and it also does not help with your mood, with your anxiety, with your self-esteem, and so it's a very difficult balance to be weighing for the risks of if someone is so paranoid that they can't get out, you want to prescribe a medication, but as someone who's prescribing this medication, to be aware that you also need to be monitoring for all these things of blood pressure, glucose, and so forth. So this is what we know it can cause. And this is the recommended guidelines by the APA, by the ADA, of getting a baseline weight, BMI, baseline waist circumference, blood pressure, blood glucose, and then routinely checking every 4 weeks, 8 weeks, 12 weeks, quarterly, and so forth, and more if there's abnormalities. And to also consider, as many people as have mentioned, if there is significant weight gain, significant elevated blood sugars and cholesterol, of considering switching to medications that are less likely to cause these symptoms. And so one of the things, as I was talking about, is that these lifestyle habits of weight and diet and exercise are very complex. We know that a healthy diet and regular exercise can improve your mood, can improve your energy level. We know that when you're not exercising and if you're eating more or eating less, that might also be a symptom of a mental illness. And as I was just mentioning, these medications also cause changes in your appetite and energy. So it's a very complicated issue of which is it, the chicken versus the egg. And so it's something that just needs to be addressed to try to tease out on a regular basis. But these are some of the barriers of trying to do this in a primary care psychiatric setting, in a psychiatric setting, is what are your resources of the setting? Is there equipment? Do you even have a blood pressure monitor? Very rarely will there be a phlebotomist or a accessible laboratory so that you can get your blood drawn. Is there an EMR, electronic medical record? Can you actually access these? If you do get the blood drawn, do you actually get the report? Can you share it with your colleagues in primary care? There's, as always mentioned, the time limitations. It's not something that's very simple to address these issues. And you're just kind of trying to decide which is the major issue, the main problem that's really upsetting the consumer who's coming in today, and making sure that though you still have to address what is going to be the thing that will ultimately shorten their lifespan. So kind of picking and choosing. And then there's just a general sense of discomfort, as Dr. Holt was saying, of, okay, we found out that the cholesterol is elevated for so what? I've changed the medication, lifestyle habits haven't changed that much. Do I want to start a medication that I don't really feel comfortable with, that I'm not as comfortable starting something for blood pressure, I'm not as comfortable starting something for cholesterol, and because these things have side effects as well. So potentially not wanting to ask because you might not necessarily want to know the answer. And as mentioned as well by many people, this difficulty communicating with multiple providers. With this metabolic syndrome, they may often be seeing primary care, they may be seeing people to manage their kidneys, to manage their heart, and that's all valuable information that would be helpful to know, but with time limitations, with a lack of technology to collaborate, it can be very difficult to get all this stuff done and not to be redundant as well, to not be drawing the labs over and over again because you couldn't communicate. So that kind of goes into a little bit of don't ask, I don't want to know. There's a little bit too much information to be finding out. So Some potential solutions would be just increased education on primary care interventions for psychiatrists. We do a lot of it goes both ways, increased behavioral health interventions for primary care, but feeling more comfortable for potentially starting a treatment for high cholesterol, statin, as well as smoking cessation. Improving communication and collaboration as the Affordable Care Act is all about, increasing collaboration, having maybe an access to a universal EMR. That might be the pipeline, but at least within different organizations and DPH of getting them more integrated. So, and then as we've been talking a lot about this integrated behavioral health primary care programs. And so, as Dr. Holt was mentioning, there's the psychiatry consultant to primary care via telemedicine or directly in the clinic located. There's also primary care could potentially be a primary care consultant to psychiatry. And what we have at the South of Market Mental Health is just having co-located clinics. So you have access to someone, and people who are really having difficulty linking with primary care, psychiatry, if they're in the same clinic, there might be a better chance for someone to come in and feel less stigmatized and able to talk and to share labs and to collaborate and come up with something that both the consumer, psychiatrist, primary care all feel satisfied and will really be improving health. So some take-home points is that health maintenance just has far-reaching consequences, both on your lifespan, your mood, your energy, and smoking cessation, because I think that's kind of a key one that really is such a leading cause of mortality and morbidity. So it should be a discussion point for every clinician, psychiatrist, therapist, anyone. And education, just more education, more discussion, more conferences such as this can really open the dialogue on more preventive care and treatment options then. So, any questions?
Hi. I'm sorry to say, Dr. Migliani, because you represent the medical model very much so. Because to me, medical model says, something wrong with you, you need to be fixed, instead of really also looking at the environment and what's going on. I'm going back again to the holistic approach of any disabilities. And that sort of like, I understand what you're saying, prevention and, all that, and then, communication among primary carers and psychiatrists and all that, but it's really bigger than that. And the foundation of disability is really that in order to overcome that stigmatization is not to look at the person only, but really look at the environment. And I think it's really, really important that you take that into consideration.
I appreciate your comment. I agree to look at the person in the holistic model. The point of this discussion was actually to take more ownership on ourselves for how we're contributing to a lot of the illness, based on the environment can cause it, but so can ourselves, so can the treatment. And that's just my take-home message of that we have to take some ownership as well, that these medications might not be as simple as treating the symptom and so forth. They have a lot of negative side effects as well.
And in terms of changing the system and making improvements, we want to try to make improvements where we can get the maximum bang for the buck. And if the physicians are willing to take responsibility for smoking cessation, that's half of the morbidity of people that are going through mental health. They're more likely to die from smoking-related problems than related to issues related to mental health or depression or otherwise. So it's not a small deal for physicians to be looking at smoking. On the other hand, the issues that you're also talking about are not a small deal too, and so we need to be looking at, okay, which of these can we do, what order should we do them, and then how do we get there to this kind of nirvana of a system that we all know that we really want. So again, I don't think it's an either or, but this is what I think the doctors in Dr. Magali's clinic are taking responsibility for, and I actually commend you because it's a really big step. It's something that, it's not intuitive, but when you think through it, it's probably the most important thing for her in her clinic to do for her patients.
And I'll add just really quickly that from a client perspective, from a patient perspective, it can be overwhelming to be bombarded with a lot of things that I need to change. And I really liked what you said about approaching smoking cessation from an economic standpoint, from saying, let's talk about how this is affecting you financially, because that's a very oblique angle to approach it from. That's not something that I would find personally threatening or that I could perceive as being judgmental. That'd be like, wow, yeah, I actually do spend more than I can really afford on that. Maybe it would be a good idea to talk about that. So it's just a matter of being aware that someone who has experienced mental health conditions might feel cornered with some of that. And I think that's something that to be aware of and to work with. Because I think what you're doing is great. What you're talking about is great. It's just a matter of presenting it in a manner to a patient that we're willing to receive.
Yeah, I had one of my patients tell me that what really impacted her about smoking is that if she stopped smoking, she was worried she was going to gain weight. And being a man, it's like what? But this is where again, gender issues come in, right? Male psychiatrists, women psychiatrists. There's opportunity for me to learn. But I hope that you'll share these stories with your doctors because you'll be teaching them what you need and how to best speak with you about the next issue that comes on up. So,
Okay, I'd like to turn to Pam Cohn. We're lucky to have an attorney on the panel. Although the last speaker, certainly not least, it's very important for patients and others and providers just to know where the legal parameters are in terms of what are the rights and obligations of patient and doctor, not just with respect to privacy rights, but under the Americans with Disabilities Act, its predecessor, Section 504, and the state laws under UNRU or any other statute. Pam?
Thanks, Steve. I know we're already past 4 o'clock, so I'll be very, very brief. So, connecting the legal rights to stigma, understanding and working to enforce your legal rights can promote your sense of autonomy, can help deal with some of these stigma issues. So we're not talking about something that's completely outside of this whole discussion of stigma. And Rob and I are working at Disability Rights California under a grant by the California Mental Health Services Administration, which is about stigma and discrimination reduction, mental health stigma and discrimination reduction. So it's really part of the same thing. Rob and I both have some fact sheets out in the front table on these issues, and there's one that's called Access to Healthcare that summarizes what's in my presentation here. So you can pick that up. Also, in case I forget to say, we also have evaluations that we have to use because under this grant. So we would very much appreciate it if you'd pick up an evaluation on your way out and I guess give it to April, and she'll get it back to us. So this is just a very brief definition of what access to healthcare means. It's both the services of the healthcare providers and the facilities themselves. And when we're talking about physical disabilities, there's a lot of detail about physical access to the facilities, but we don't need to really talk about that in the mental health context so much. These are the laws that the rights come under, the ADA. Title II is public facilities, and Title III is public accommodations, which is fairly confusing. Public accommodations are private facilities that serve the public, but the law is similar under both. And then there's Section 504, which applies to facilities that get federal funds, which is virtually all facilities, and state laws, but it's not really important for you to know where your laws come from. I just kind of like to let people see the list. So you can divide the law about access to health care, and again, I'm talking about access to health care now strictly from like an anti-discrimination perspective. There's all kinds of other legal issues involving access to health care that we've like touched on here, managed care barriers and things like that, and HIPAA, but I'm going to just talk about this particular, from this particular perspective. So you're entitled to full and equal access to healthcare services and facilities. This applies to people with physical disabilities as well as people with mental health and cognitive disabilities equally. And that is essentially a non-discrimination mandate. And then there's the right to reasonable accommodations. Reasonable accommodations are defined this way as reasonable modifications to policies, practices, and procedures that are necessary to make the healthcare services available to people with disabilities. And then effective communication. And so we've already talked a lot about effective communication. It's largely discussed in terms of auxiliary aids and services. Anything that is required for a physical disability, like if someone has trouble hearing, you have to give them there's information in print. If someone has trouble seeing, you could give them the information in spoken form, but it also, and sign language interpreters for people who use sign language, but it also applies to people with mental health disabilities and cognitive impairments. I hadn't really thought about this before, but I think telepsychiatry is sort of a good example of a form of effective communication for some people in some situations. You wouldn't want to force it on someone, but there may be people who have such barriers to coming into an office that that's their form of effective communication. Cultural competency is another, cultural and linguistic competency is another issue that's related to effective communication. I have some slides about that later. So here's more detail about discrimination. Here are some examples of what could be discriminatory conduct in a mental health, healthcare context when we're talking about people with mental health and cognitive disabilities. One is requiring someone to take a companion in with them to an appointment. If the person wants to go in alone, and that does happen, we'll only see you if you bring the person who's sitting in the waiting room with you. That's not okay. Another is just the blatant refusal to provide services, which we've seen a couple of examples here. It is not okay to just walk away when you see the word schizophrenia on someone's chart. That's just a really, I'm going to use that example for now as my blatant example of outright discrimination. And then harassing someone, making disrespectful comments is another form of discrimination. So then we get to reasonable accommodations. An accommodation is only reasonable if it's not an undue financial or administrative burden to the healthcare facility. So it's a balancing act, and accommodations are negotiable. So there has to be a connection between the accommodation you're asking for and your actual disability, what you need, and it has to not be an undue burden. So here are some examples of reasonable accommodations in the mental health context. Allowing a support person to come into an exam or a consultation if the person wants to bring the person that's in the waiting room with them. So it would be discrimination to require you to bring the person in with you, but it would be a failure to provide a reasonable accommodation if you didn't allow the person to come in. And then there's confidentiality issues, and you may, need to explain that to the person who's coming in. But another one would be allowing a psychiatric service animal. Unfortunately, this does not apply to emotional support animals anymore, but you do have a right to a psychiatric service animal, the distinction being that a service animal is individually trained to perform a service for the person with a disability that's related to the person's disability. Sometimes people with mental health disabilities need to have appointments at specific times, either because they have trouble waking up early in the morning because of the medication they're taking, or because they have other mental health, other types of appointments that conflict with the appointments that are available. whatever. There needs to be some flexibility in scheduling for that reason. And then taking extra time for a consultation, that I think is mostly applying to people with cognitive impairments who really need extra time to have things explained to them, and that has to be done. Of course, it would be unreasonable if you expected the doctor to take all day with you, but you do have to allow a reasonable amount of time, and you have to use formats that are accessible to the person. And then these are just other rights that I just wanted to bring up, that it's not just about discrimination. It's important to know what your rights are in the healthcare context, other than discrimination, and these are just some of them. Discharge planning is a pet peeve of mine right now because I've had such negative experiences with clients being in hospitals, and the hospitals just not knowing what a discharge plan is. And it's such an opportunity to get care, both mental health care and physical health care, after you're discharged from someplace. But people don't know they have a right to a discharge plan, and very often it just doesn't happen. People who have conservators need to know that they have the right to challenge decisions of their conservators. And then there's the whole HIPAA confidentiality thing. You should know that you have a right to access to your medical records, and also to have your medical records confidential. HIPAA applies to all kinds of health information, not just psychiatric information. I'm not aware. I'd like to talk to you, Jillian, about this issue of the consent, because I'm not a HIPAA expert. I mean, that would be really awful if you couldn't get, if that's what's happening. So I don't know about that. I do know the psychotherapy records are treated differently, but just the psychotherapist notes. Otherwise, my understanding of HIPAA is that mental health records and physical health records are both, HIPAA both protects the confidentiality and also gives you access to those records. But you don't want to make it, you don't want, of course, HIPAA to be a barrier to getting health care. It's supposed to help you. And then we've talked a little bit about culturally and linguistically appropriate services. The Civil Rights Act, and there's an executive order that says that recipients of federal funds, which is most, if not all, healthcare providers, must take reasonable steps to ensure that people with limited English proficiency have meaningful access to programs and services, including healthcare services. So you basically have a right to services in your language. It may not be a psychiatrist who speaks that language. If it's a language that they can't find a psychiatrist who speaks, it might be an interpreter. But you do have that right. And then, as Steve was saying, the HHS has not promulgated regulations about this yet, but they do have standards. There's a national standard for culturally and linguistically appropriate services in healthcare that says that that healthcare providers should provide effective, equitable, understandable, and respectful quality care and services that are responsive to diverse cultural health beliefs and practices, preferred languages, health literacy, and other communication needs. So this is a really interesting topic all by itself. We did a seminar here once that focused on that issue too, but it's good to know that you have that right. And then this is how to address discrimination, the levels that you take it to. Talk to your healthcare provider first if you have a concern. The healthcare provider may not realize that they're doing something that's discriminatory, and sometimes will change their practices if you bring it up. So you can talk to the individual provider, or you can also, many healthcare providers have ADA coordinators. You can talk to that person. And then you can file administrative complaints, and then I just give information for how to file administrative complaints. Now, full disclosure, this can be a very lengthy and difficult process to file administrative complaints, so I'm not saying this is an easy way to go, and that's why I would definitely go internally first to try to work it out. But, it does sometimes bear results, and agencies like mine can help walk you through the process if you need help with that. So there's just different agencies. We don't really have time to go through all this right now, but some of this information is in the fact sheet that's outside. be aware that for the administrative complaints with the federal government, it's a very short deadline of 180 days from the time that from the thing that you're complaining about. And then there's also the Department of Managed Care, which is, a lot of these issues have now become managed care problems, and so that's another route if your issue involves a managed care problem. And Medi-Cal fair hearings. Oh. And that's us. And that's Kelly's. So I'm sorry to rush through all that, but that's...
Well, we'll put you on first next time, Pam.
Sometimes talking fast has its advantages, I guess.
So this is the end of today's seminar, and thank you very much for your attendance and participation. People with Disabilities Foundation's next seminar will be on the topic of prisons and mental illness. And we ask the question, are prisons warehouses for people with mental illness or developmental disorders? If you would like to stay informed about that seminar, please be sure to sign up for our e-newsletter. So I'd ask to please give a very, very sincere round of applause to our speakers for generously giving their time and expertise today. Thank you, and thank you all for coming.